Good morning, good afternoon, good evening, everybody. Welcome to the global launch of the COVID-19 Safe Abortion Response Map. We're so thrilled that so many of you are on. This webinar is co-presented by the IBP and the Prevention of Unsafe Abortion Partners Group, which is led by the WHO's Human Reproduction Program Group. Next. I'm Eva Lathrop. I'm your moderator today. I'm the Global Medical Director at Population Services International, or PSI, and I'm a member of the Partners Group that is leading this webinar today. Next slide. And I'll turn my video off for the purposes of bandwidth, but good to see everybody today. So what is this Preventing Unsafe Abortion Partners Group, and what is it that we do? By way of introduction, let me tell you about it. The Prevention of Unsafe Abortion Group, or the PUA Partner Group, was formed in June 2020 as a response to COVID-19. This group aims to facilitate information sharing, collaboration, and coordinated action among partner organizations working on prevention of unsafe abortion in the context of COVID-19. The partner group is chaired by UNDP, UNFPA, UNICEF, WHO, and the World Bank Special Program, HRP. And members include a number of different organizations working to support comprehensive abortion care work. As a starting point, this group identified action points at both global and country level. These action points were then narrowed down to a range of immediate tasks, and this process resulted in 4 work groups. The first was guidelines and recommendations. The second was mitigation of compromised access to abortion. The third, procurement funding flow. And the fourth, which is the group that we'll talk about today, is the adaptations and indicators group. Our primary objective of this group was to consider abortion service delivery in the context of COVID-19, the success or impact of program adaptations, and how to sustain adaptations to service delivery that have proven successful post-pandemic. This task force is chaired by PSI. Next. Over the course of the next hour, we'll cover quite a bit of ground together, starting with an introduction to the Safe Abortion COVID-19 map, followed by 4 fantastic presentations describing 4 different adaptations made to safe abortion and PAC programs to protect access to comprehensive abortion care in the context of the COVID-19 pandemic. And finally, we'll explore best ways to continue to use the Safe Abortion Map and the utility it could have going forward. Next. But before we get underway, a few housekeeping issues. First of all, please submit your questions anytime. Please put them in the Q&A box at the bottom of your screen. We'll try to address all of these questions before we run out the hour. If we're not able to, we will provide an email response document to participants. French translation is available, so if you need that, please click on the world icon at the bottom of your screen, and that will allow you to access French translation. This webinar is being recorded, and it will soon be available on the WHO Media HRP YouTube channel. Next. It is likely, we don't know the full extent yet for sure, but it is likely that the COVID-19 pandemic has had devastating impacts on women's ability to access safe abortions. The suspension of family planning outreach programs, movement restrictions, disruptions in supply chain, and fear of contracting COVID-19 have all prevented women from being able to make informed and safe reproductive health choices. As part of the work of the Service Delivery Adaptations Work Group, we developed an interactive tool that highlights how organizations adapted their safe abortion and post-abortion care, or PAC, programs to maintain service delivery while seeking to protect their clients, staff, and communities from contracting COVID-19. Next slide. The team working on this idea conceived of collecting and sharing program adaptations in an interactive map form not only for the sake of documentation, but with the intention that this be a living database. So we developed a tracking and documentation tool, and again, a living database meant for peer-to-peer learning and safe abortion and post-abortion care throughout COVID-19. We collected data from November to January 2021, although the data we collected reflected adaptations that were made from the beginning of the pandemic. The map contains an interactive legend, you can see that on the left, to filter map categories, and each adaptation includes the sector, description, results, and contact information to get more information and connect with colleagues. I've shown you a still shot here rather than the live map given bandwidth, but this still, you can go back to the previous slide, sorry. So you just have a still shot here rather than the live map. Given the bandwidth, it would be really hard to play with the map on a live webinar. But this demonstrates an example of the type of information that can be found as you interact with the different adaptations. Next. So the map documents 43 adaptations across 19 countries. Over half of the adaptations were from the private sector. The majority included some digital components, some pivot to digital care. And service delivery, provider skills, and capacity building were the most frequent adaptation categories. And we will learn about one adaptation from each of the partners who contributed to the map today. Next. One of the unique features of this tool that is different from other COVID-19 program adaptations maps that may have been presented here before is the addition of several qualitative components that allow the user to explore some of the map adaptations a bit more. For example, this is a still shot of an interactive story that allows the user to better understand the impact of adaptations by following this client through her safe abortion journey from her home. Next. To maintain quality services in the pandemic settings, provider trainings remained a top priority. This section of the tool allows the user to listen to providers' experiences of their COVID-19 safe abortion values clarification training and MVA training in Burundi. Next. And finally, this section allows the users to deep dive into several digital adaptation stories that can be found at the end of the tool. I know this has gotten you all interested in visiting the link to the map, so you can dive into the learnings, and I'll indeed share that with you at the end of the hour. But now let's hear from 4 people whose creative, quick thinking, flexibility, and willingness to pivot programs in ways that allowed access to safe abortion and post-abortion care services to be preserved during the COVID-19 pandemic. Next. We'll start with Dr. Kateera, who will present an adaptation from the Sudan Family Planning Association. She will talk about a call center that was developed specifically to address needs during the COVID-19 pandemic. Next slide. Dr. Kateera is the coordinator of Sudan Family Planning Association's telemedicine project. She graduated from the University of Khartoum Faculty of Medicine, and she holds a community medicine master's degree and is currently the senior registrar of community medicine. She has 7 years of experience in public health, specifically in the areas of maternal newborn child health and adolescent health. And she's made major contributions to reduce maternal mortality by improving access to family planning methods and building capacity of healthcare providers. Next. So now let's hear from Dr. Kateera.
Good afternoon, everyone, and good morning and evening to our colleagues joining from other countries across the globe. Welcome. I am Dr. Kateera Ahmed, Technical Lead at Sudan Family Planning Association, the IPPF member association in Sudan. It's my pleasure to join this session today to be able to share SFPA experience of establishing a call center as a response to the ongoing COVID-19 pandemic. I will start with the Sudan context, COVID-19 situation, and a very brief history of SFPA. Next. Sudan is a country of great diversity in terms of topography, ethnicity, language, social norms, and living conditions. In terms of reproductive health, maternal mortality ratio in Sudan is one of the highest in the region. There is high unmet need for contraception by about 26.6% and low CBR by 12.2%. And abortion is one of the leading causes of maternal mortality in Sudan. It's a country that undergoing transformative change in recent years. The conflict, the chronic poverty, the underdevelopment, and this economic sanction, all of these factors make Sudan a special case when we are talking about COVID-19. Sudan health system was already weak and deteriorating. In combination with the COVID-19 situation impacts the availability and accessibility of SRH services. Sudan Family Planning Association has been providing services to communities in Sudan since 1965. SFPA is present in 13 out of the 18 states and working on plans to expand to other states in the future. Through our networks and approaches, we have been able to reach a huge proportion of the Sudanese population with services. As part of the lockdown measure, SFPA was not able to provide SRH services through its usual channel. And as a response, SFPA established its call center. Next. The overall goals of the call center was to minimize the impact of pandemic on SRH post-abortion care services. The specific objective were to enable to continue access and utilization of SRH post-abortion care services during the pandemic, and to ensure that vulnerable group of people who might not be able to access the static health facilities, including people living with HIV, people in remote areas, displaced, refugees, and nomads are able to get service. And also to respond to emergencies, especially the bleeding emergency like threatened abortion, incomplete abortion, by offering counseling and referral services. And also to respond to SVBV cases by providing counseling, timely referral, and psychological support. Regarding the call center establishment, I will talk about the plan, training, and launch. In terms of planning, we developed a strategic partnership with Ministry of Health, the Sudanese Society of Obstetrics and Gynecology, and other NGOs like Red Crescent to work with us. Instead, we do not have static facilities on it. We also mapped which clinics were still open during the pandemic, which was important for making referral for pleading cases and other emergencies. We set up with 3 obstetric and gynecology consultants, 1 family physician to take the call. We later expand to 10 obstetric and gynecology consultants and 4 family physicians. They were experts, but we provided them with refresher training and training on what we call the call center package, which included call center technology, effective communication with client on the phone, psychological first aid, and counseling on different SRH post-abortion care issues. We had 1 unified number, and we worked to promote the call center through SMS, radio, social media, and TV. We work closely with the largest telecommunication companies in Sudan on SMS Plus to client, which drove traffic to the call center. We adapted our routine client register to the call center, and we have an application for data entry and recording. From the beginning, we put in place safeguarding measures. For example, we had a beneficiary feedback mechanism as part of the IVR system, where clients were able to report on their experience of using the call center. Monitoring and evaluation was very important to us to understand the impact of this digital health intervention. We had system reporting, where we capture call, service provision, and referral. Also, report by day, agent, call recording to enable improvements to service delivery. Regarding the service delivery model, our cluster are on call in case of emergency and connect with the call center, and we refer our client to a nearby community-based distributor to receive family planning. We also make referral to the Ministry of Health clinic, and we also establish a WhatsApp SMS system where a client can write in question and send lab results. Regarding the data from the call center, the total number of calls we received between April and October was 89,450 received counseling and awareness through the IVR, and 9,900 clients received direct services from the call center provider. And those we offer them counseling, consultation, and referral. And sometimes we provide investigation and treatment according to the client situation. Majority of the callers calling in were female at 71%, and 29 were male, and majority were over 25 years. However, 18% were through the 18 years of age. Call received from the 18 states of Sudan, and the most requested services were contraceptive, infertility, and antenatal care. Regarding the post-abortion care in the period between April and October, we received about 156 clients, most of them aged between 25 and 30 years, and all of them offer counseling and some offer medication, and 30% of them had been referred either to emergency department or SFPA clinics. Next. Regarding the lesson learned and next step, the overall picture that the call center has a positive response from the communities, partners, and providers. We have the unique picture of call center. On it, we have girls talking about the unintended pregnancy and their desire to have abortion. Men talking about their sexual problems. Now men are more engaging in reproductive health issues. Traditionally, SRH was seen as a woman issue, but through the call center have seen increase in male engagement. We have women talking about their loss of libido. Usually libido is not an issue. Women talking about it due to culture, but the privacy in the call center made women more comfortable to talk. We have young girls asking without barriers about their reproductive rights, and people living with HIV asking without stigma, and women with long-standing symptoms, financial barrier, and now contacting us. SMS is a popular method of promoting traffic to the call center, and working with telecommunication companies was very important. We plan to sustain and expand. We are planning to sustain the call center and bringing in-house in partnership with key stakeholders, and to continue to promote the call center and looking out how to reach the hard-to-reach population. And also, we will develop a mobile application in order to have a comprehensive service. The call center is a successful story of SFPA, but always challenges do exist in terms of supply chain disruption and high cost of in-country distribution, lack of PPE, especially for community distributor, and staff availability. That brings me to the end of the presentation, which I hope participants found useful. I would like to thank the organizer for the opportunity to share our experience, and would be happy to take any question in the Q&A session. Good afternoon.
Thank you so much, Dr. Kateera. Next, great. Next, we'll hear from Rachel Misra, who will discuss Choice in Her Hands, the launching of a telemedicine project for home-based safe abortion care. Next. Rachel is a senior digital health advisor for MSI Reproductive Choices. She spent 10 years working in digital marketing and digital experience management with health organizations. The last 3 have been with MSI. Rachel focuses on enhancing the delivery of sexual and reproductive healthcare information and services through digital technology, including through MSI's telemedicine programs, which Rachel will speak about today. Next. And we'll hear from Rachel.
Hi everyone, I'm Rachel Misra, the Senior Digital Health Advisor for MSI Reproductive Choices, and I'm delighted to talk to you today about the launch of telemedicine for home-based safe abortion care, specifically during COVID-19. So prior to the pandemic, our safe abortion services were delivered predominantly through in-person care channels, so through our centres, through outreach, and through our partnership sites. When the pandemic lockdowns were implemented, this threatened access to safe abortion care services due to many aspects of the pandemic, such as movement restrictions or fear of catching COVID-19 at healthcare facilities. MSI UK and our South African programme set up telemedicine services, which were drawing on the example of MSI Australia. And they had launched telemedicine prior to COVID-19, so it was a well-established model, and it's shown that telemedicine MA services are just as safe as in-person care. In South Africa, there was a clear need for telemedicine services. So during the pandemic, there were heavy restrictions on movement. So this caused a range of complications. So, in terms of privacy, it was harder for clients to explain where they were going. There were issues around public transport and making appointments. Permits were required to get to a service, and only the person receiving the service would be able to leave the house. And the pandemic aside, so before the pandemic, 60% of pregnancies in South Africa are unintended, and over half of abortions that happen are unsafe. So in South Africa, telemedicine was launched to protect access and expand safe services to rural, underserved communities. So the Health Professionals Council of South Africa released guidelines for good practice in telemedicine, which was used to guide the telemedicine model. So just to quickly run through the flow, so there was an initial screening with our contact centre, which kind of covered some preliminary points, and then if a client was deemed eligible for the full consultation with a provider, an appointment would be booked. The provider would then call the client and do a full eligibility assessment and do a consultation to ensure that the client was comfortable of what the process would entail. The client could then pick up the product from either one of our centres, or it could be delivered to their home. They would have access to a 24-hour helpline, and also our contact centre would follow up with them to ensure that everything seemed like it was in order. So as a result, women could access safe abortion care from the comfort and privacy of their own home. And we also saw that 1 in 10 telemedicine clients were based in regions that weren't previously served by our centres. So we've seen that telemedicine has been able to expand access to those in underserved and rural communities who may have otherwise sought unsafe abortion. To expand a bit on the results, so the results have shown that telemedicine was able to protect access somewhat with a service that was just as safe and effective as in-person care. So in South Africa, the programme has seen over 6,800 clients with a 99% efficacy rate. It's a cheaper service in comparison with the one that can be received in our centres, and it's reaching women that were not previously served by our centres. And client feedback shows that the service is deemed to be confidential and more convenient. And also, just to quickly speak to our UK telemedicine service. So a BMJ study that included our service offering and results showed that telemedicine was just as safe and effective as in-person services. We could see that there were reduced average wait times, which went from almost 11 days to 6.5 days. Clients showed a strong preference for telemedicine services, and even now that the pandemic lockdown restrictions have lifted somewhat, 2/3 would still say that they would prefer the telemedicine option. And any clients who are uncomfortable with visiting a clinic now have another option. So just to run through a few of the lessons learned from delivering telemedicine. So telemedicine can bring down waiting times and average gestation, and results have shown that it's just as safe, effective and acceptable as in-person care. Telemedicine provides an opportunity to reduce unsafe abortion by expanding our reach and providing for those who may not otherwise have had a safe service. To be client-centred, we really do need to offer telemedicine because clients are showing a strong preference for this method of abortion delivery. Confidentiality, privacy and convenience are key, and this could mean that we can expand access to more vulnerable clients who may have issues around coming to a centre. We've seen that there can be a strong preference for both courier and pickup options, and both of them can serve different people in different ways. So like any model that expands access to SRHR, there's going to be opposition. So we are being extremely careful around the legal and regulatory environment to ensure that what we're doing is in alignment with the regulations of the country. And then finally, telemedicine is not going to be the only solution. So to protect choice, in-person care still must be available for those who need it or would prefer it. So for example, if someone who's seeking a service after the first trimester or a previous unsafe abortion attempt. So the next steps for our telemedicine adaptation. So using the learnings from reaching over 22,000 clients in the UK and almost 7,000 clients in South Africa, we are, and obviously the existing programme in Australia, we are advocating for access in the UK to be made permanent, and we're also exploring pilots in new programmes, for example, in Ghana. Thanks a lot.
Thank you so much, Rachel. That was fantastic to hear. I'm sure there'll be lots of questions. For our next adaptation, we'll hear from Katia Amado as she presents Pathfinder Mozambique's adaptation to post-abortion follow-up during the COVID-19 pandemic. Next slide. Katia is an SRHR activist and feminist. She's passionate about sexual reproductive health and rights, contraception and safe abortion as themes that contribute significantly to the development of girls and women and gender equality. She's a medical doctor by professional background, and she currently works for Pathfinder International in Mozambique as the SRH technical lead, aiming to positively contribute to Mozambique's transformation into a country where access to SRH information and services is free of stigma and discrimination at all levels. Next slide. And next again.
Good day. I'm here to share with you Pathfinder Mozambique experience about post-abortion clients follow-up during COVID-19 outbreak by providers through phone calls. Mozambique was no exception to COVID-19 challenges, and initially, the government actions were focused on resources prioritization and lockdown measures implementations to respond to COVID-19 that had an impact in health sector, in particular to the regular offer of safe abortion services, either because of unavailability of providers, mostly due to their rotation among the health facility essential classified services, and at that time safe abortion was not one of them, and because of clients' fear to visit health facility. Pathfinder Comprehensive Abortion Care Program includes, among other initiatives, the collaboration with local NGOs with community activities, having community health workers to provide information, referrals, and post-abortion clients follow-up, behavior change sessions at community to enable a favorable environment for abortion, in-person provider support such as trainings, mentorship, and supportive supervision, and commodity security task forces implementation at national, subnational, district levels, and health facilities. With the COVID-19, in-person activities at health facilities and communities were interrupted. Therefore, we had to shift to virtual-led sessions using digital technologies and start the remote clients follow-up by healthcare providers and CHWs. We consider the remote support to clients to minimize the numbers of visits at the facility and risk for COVID-19 infections after an abortion, an innovative response to ensure continuity of care and quality. The provider calls the clients and assess presence of any danger signs and confirm the abortion process. The conversations covered what the client saw during her abortion, the patterns of bleeding and abdominal cramps. Remotely, clients' follow-up contributed to reduce the pressure at the service delivery point, to avoid and prevent unnecessary waste of additional resources, to maximize opportunities, to reinforce post-abortion contraception messages, to confirm absence of abortion-related complications registered at the health facilities even after the COVID outbreak. Regarding challenges and lessons learned from this adaptation, service provider is overwhelmed, mostly in high demanding sites, because the service attending provider is the one making the calls. Despite being overwhelmed, providers remain committed at maintaining the quality of services. However, these providers-initiated phone calls are not sustainable, as providers are using personal resources to make these calls. Privacy and confidentiality issues. Concernings around privacy from providers using personal phones and clients who may not be willing to talk about abortion over the phone are likely to be the major challenges we need to address. This could entail moving from providers-initiated calls to facility or client-initiated calls. Some clients do not have phones, which may limit to reach all eligible clients. We have learned that we could still support the large majority of clients with this virtual support, as the majority of them had a phone or could be able to call the provider if given a number to reach out. What will our next steps with this adaptation be? Pathfinder has piloted a standardized questionnaire to support ongoing practice that aim to exclude any complications such infection or hemorrhage and confirm that the abortion process successfully took place. We hope to improve it and scale up this approach to reflect the next steps below. To discuss with national authorities so they can adopt the adaptation in a more sustainable way. We expect to build on this implementation to advance conversations on safety of self-care and telemedicine, and advocate with the national health system to pilot self-care in order to gather evidence on its safety and feasibility. Kanimambo, thank you.
Fantastic, Katia. Thank you so much. And for our final adaptation, we'll hear from Ando Tiana Raobelison from PSI Benin, who will discuss an adaptation designed to maintain continuity of safe abortion and post-abortion care services during the COVID-19 pandemic via virtual support for providers and pharmacists. Next. Dr. Ando is a medical doctor by training. She's a public health professional by passion, and she has a university diploma in tropical medicine, contributed to the West Africa Ebola response with another humanitarian organization prior to joining back to PSI as a boomerang. We love our boomerangs. And she's currently in charge of programs for ABMS PSI Benin, including overseeing the COVID-19 adaptations. Next.
Good day, everyone. This is Ando Raobelison from PSI Benin. I'm the Deputy Country Representative and the Deputy Director for Programs. And it's my pleasure today to talk with you about how PSI Benin tackled the challenges posed by COVID-19 to maintain the continuity of safe legal abortion and post-abortion care services using virtual support to service providers and pharmacists. Next. When the COVID-19 pandemic hit Benin in March 2020, the government has introduced preventive measures such as mobility restrictions, suspension on public gatherings, social distancing, and recommendation to opt for telecommuting. Those measures were feared to negatively affect the provision of safe abortion and post-abortion care services and their use by potential users. So PSI Benin thought that it was good to rapidly adapt its works in the field to follow COVID-19 safety guidelines while addressing the challenges. And such challenges include obstacles in physical access to the health facilities, limited face-to-face interactions, fears of exposure among community and providers, and misinformation on availability of services, which results in slowdown of client flow to facilities, but also to disruption of medical detailing visits. These challenges made it indeed difficult for us to serve women's reproductive health needs, and we thought it could potentially translate in fewer services delivered. Next. So to continue to provide safe abortion and post-abortion care services while mitigating the risk of COVID-19, PSI Benin decided to operate adaptation in its programming, which consisted of switching to virtual interaction in lieu of the traditional face-to-face medical detailing visits, and this by using digital tools such as WhatsApp, SMS, and Teams to reach its service providers and pharmacists. Next slide. Thanks to those innovative communication technologies, an average of 315 providers and pharmacists from the private sectors were guided daily by PSI Benin medical detailing agent on safe legal abortions, on post-abortion care, and on medical abortion and contraceptive products, proper use, and posology. Next slide. As you can see in the graph, we can tell that the use of digital tools helped PSI Benin to effectively and efficiently carry out medical detailing visits, with more than 10 times visits conducted virtually compared to the same period pre-COVID by face-to-face. However, we have to say that the connectivity appeared to be a challenge for many of our providers and pharmacists, which led to the a slight drop in the figure from June to August 2020. Next slide. Nevertheless, we can tell that PSI Benin was able to relatively maintain the provision of safe abortion and post-abortion care services, pointing to the role of the virtual support that we've provided to our partner service providers and pharmacists. As you can see on the slide here, the safe abortion services and the PAC services provided keep the same trends during 2019, when COVID was not raging yet in Benin, compared to 2020, when it was in the midst of the epidemic. Next slide. The adaptation that PSI Benin has operated to address the challenges posed by COVID-19 provided us lessons for maintaining the continuity of ASAPAC services in times of public health emergencies such as the COVID-19 pandemic. What I can share first is it was found that digital tools are increasingly essential in facilitating service provision, especially as a mitigating measure during events that might disrupt the health system. Second, we realized that the majority of our medical detailing agents and our service providers have difficulty to access to stable connectivities and to deal with virtual communication. Hence, we think the importance of building digital capacities here in Benin. Which leads us to my next focus about what might be our next steps with adaptation. The plan is for us to continue to use both the physical approaches, which is a face-to-face medical detailing, but also the virtual one using the digital tools, even in the post-pandemic time. Also, as I mentioned earlier, we need to build the digital capacities of our stakeholders, and therefore the need for us to find the adequate resources to support them in acquiring the smart devices, but also to access a more stable connectivity. And another point in our plan is to invest in advocacy campaign to make it possible in the Benin context to leverage the telemedicines, and more specifically to explore the potential to provide virtual counseling and consultation to our beneficiaries, but as well as to the possibility to place online order and to do doorstep delivery of medical abortion products. And that's it from my side. Thank you for your attention. Good day, everyone.
Thank you so much, all of our presenters. These were fantastic stories for, I'm sure, all of our audience to hear as well. Before we move to the next section, we would love to hear from you all with a couple of poll questions about whether or not you think you or your organization might like to add adaptations to the map, and going forward, how you think you might use this resource. So let's go to the first poll question. We'll give you 15 seconds or so to go ahead and answer. Okay, so lots of you are interested or not sure yet. The vast majority are either really interested and plan to, not sure yet, and that probably requires some discussion and looking back at what you've done. And very few said no, so that's fantastic. And our next question is how you think you might use this resource in this map going forward. Okay, lots of variation. We were able to pick multiple answers here. So lots of interest in using the map, sharing lessons with stakeholders, connecting with partners, identifying partners in country for collaboration as an advocacy tool, etc. So this is super helpful. Thanks all of you who answered. We'll take this back to our group and try to enable some of these desires for use. So now let's dive into a brief exploration of what we do now. Beyond documentation of these 46 adaptations and deep dives into some of them, how best can we utilize this map? And how can we build upon it to learn more and more? To talk with us about this, our next speaker is Ulrika Rehnström. She has been our fearless leader of the Prevention of Unsafe Abortion Work Group. She comes to us from HRP and the WHO Department of Sexual and Reproductive Health and Research. She joined the department in January of 2019. She came from UNFPA before that, where she was working as the deputy representative in Laos. She joined UNFPA originally in 2005 as an associate program officer in Bolivia. She went on to become a midwifery specialist for UNFPA in Juba, and in 2010 joined the head office for UNFPA in Pyongyang, DPRK. She has a PhD in medicine and reproductive health from the Karolinska Institute in Stockholm and a master's degree from the London School of Hygiene and Tropical Medicine, the University of London. Next slide. Ulrika, take it away.
Thank you so much, Eva. So as we have seen today, the COVID-19 Safe Abortion Response Map highlights how 6 international organizations adapted their safe abortion and post-abortion care programs to the COVID-19 pandemic. And the map captures their stories of resilience and their digital innovation and persistence advocacy to maintain access to safe abortions and post-abortion care during the pandemic. And one of the strongest ways for humans to bond has always been through storytelling. And storytelling is powerful. A vivid and relatable story can raise awareness and influence opinion and lead to change. And the COVID-19 Safe Abortion Response Map tell remarkable stories, as we have heard today, with maps and pictures that both inform and inspire. So how do we see that the COVID-19 Safe Abortion Response Map be used? We saw already your responses there, and we have had similar thoughts. We believe that this tool can be used in many different ways. It can be used to raise awareness to maintain safe abortion service delivery during COVID-19 and other pandemics. And it could be used to generate evidence for policy change or evidence for emergency preparedness and response. And you could also use the story map to facilitate regional and country learning, encourage cross-organizational and collaboration and exchange, like we have done with the PUA partner group. And story maps, they are never done. Story maps are continual works in progress. As some steps are in process, are completed, new ones get prioritized and additional steps are added. We also see this story map as a living tool, and we are planning to reassess and update this story map regularly as a collective effort to grow this story collection. Therefore, we have created a modality, a template for you to contribute to the COVID-19 Safe Abortion Response Map. And in the chat, we will share the link to this form, so you will be able to provide your own story about how you have adapted safe abortion and post-abortion care programs to the COVID-19 pandemic. And of course, you can reach out to any of us if you would like to know more about this tool or how you can contribute. So over to you, Eva.
Fantastic, Ulrika. Thank you. Next slide. And finally, here's the link to the map. I hope you will find time to use this link to pursue and peruse all of the adaptations and stories and think about adding your own adaptations so we can continue learning. Next slide. And finally, I thank you to all of our fantastic presenters. We do have a few minutes for Q&A with our panelists, and then hopefully we'll have some time to address the questions in the chat. Given the hour, my guess is we won't have time for that. I know some of those questions are being answered now live by our panelists, and we will create a document of written responses to share with participants after this webinar. So I'll start first with Dr. Kateera, and I'll go in the order of presenters. Kateera, you ended your presentation by putting forth some of your thinking about scaling up the hotline in Sudan. Can you give us a little bit more information about how you might do that, what some of the challenges might be and some of the constraints?
Okay, one of the challenges is the shortage of human resource for call center. In the middle of the project, we faced by our need to have more care provider due to increasing calls. So we solved it by making partnership with medical companies as a part of their social responsibility. But now we should think in more sustainable approaches in order to sustain our work and to continue. Other challenge is to make calls free. We don't charge clients for consultation, but still telecompanies have charge for calls. So we need to make more advocacy with them to make it totally free.
Thank you. I know you'll do it. So we'll look forward to hearing how you continue to be able to sustain it. Thanks, Kateera. Rachel, you described an adaptation. You've gotten a lot of questions in the chat about it, to abortion care in South Africa and in the UK. And by the data you provided seemed to be successful by a number of different measures. And in discussions that you and I have had, we've also noted that these are both unrestricted settings. They both have strong courier services where remote delivery of services is already a well-established practice. But as you think about adapting some of these learnings to other country programs that may not be as well suited, how are you thinking differently, if at all? And what will you take from these learnings? And how will this have to be done differently? Over to you, thanks.
Great, thank you. So telemedicine was a really ambitious service for us to launch. So it's great that we started in countries with, stronger networks of couriers and clients who are used to receiving remote services. So it's really given us like a best practice guide. However, when we're thinking about bringing it to other countries, some of the questions that we're thinking about is straight away from the beginning, is it going to be a sustainable or funded service? Because that really changes how we put the model together. We're looking at how do we ensure reliable courier of product where courier networks may be less established. So do we work through, for example, pharmacies that we have strong relationships with? Do we kind of focus on pickup and through our centres? And then we're also exploring, are there ways to reach the kind of hardest to reach using our community-based mobilizers and kind of using phones to connect people that may not have phones. So we have to be a bit more creative. And one of the programs, our program in Ghana, is currently in the process of setting up a telemedicine service, which will have equal focus on the operational delivery and research. And I think a lot of the learnings that will come from Ghana will really guide the rest of our country programs who may have more in common with Ghana than with the UK and South Africa.
Yeah, we look forward to hearing more about that as you develop that. Let's go to Katia. Katia, I know you're deeply invested in moving the field of abortion care and post-abortion care more towards self-care. And I'd love to hear more about the lessons learned from this PAC adaptation and some of the evidence that may support self-care and abortion care. Over to you.
Thank you, Eva. Well, regarding the lessons that we learned, I would like to add that this adaptation is not yet sustainable unless we do integrate as a regular support to clients from the providers, and also to the clients to have opportunity to seek their own abortion process track. And this is what Pathfinder pretends to do as as we presented the next steps. And self-care, if we see our law, although abortion still is decriminalized under certain circumstances, Self-care is not, is still a crime. So we are aiming to be able to pilot a standardizing approach to this adaptation, so we can have a proper pilot that might help us to advance the conversations with the Minister of Health regarding self-care, safety, and quality. Thank you.
Thank you. Lots of work left to be done. We're looking forward to hearing about it. And finally, over to you, Dr. Ando. This is a fantastic story of one of many adaptations I know the Benin team put in place during the pandemic to continue access to abortion care. Very briefly, could you describe one of your other adaptations? And if you haven't done so, propose how you might evaluate it. You don't have much time to answer that question, but go for it.
Okay. Thanks, Eva. Thanks, Eva, for the question. I would say, in addition to the shift to virtual medical detailing visits that we've been doing, we had another adaptation for using virtual replacement of our demand creation activities, which consisted of using social media platforms and to tell the potential users that PSI affiliated clinics are still open, that it's safe to access them, and that the safe abortion services are still available. For your second question, I have to admit we haven't done evaluation yet, but we are really eager to do so, especially to demonstrate the effectiveness of such adaptation. Because as I've mentioned in my presentation, we plan to combine both physical operations and virtual approach. So we might, if we are given the possibility, we might want to evaluate and learn what is and what is not working in the way we have been operating this virtual approach. And also, this is in terms of usability, in terms of quality of services, and also in terms of satisfaction of those who have been working with. But this is tending to financial resources, and if we are given the opportunity, we might put it in place. Thank you for the question.
I appreciate your mention of making sure that the client voices are included in any evaluations that we do, and it's a big priority for our group to look towards evaluation of some of these adaptations. Next slide. And finally, a big thank you to everybody who presented today. The panelists gave us really beautiful descriptions of their creativity and innovation in protecting access to abortion care throughout the pandemic. To all of our teams behind all of the other MAP adaptations that we didn't talk about today, and all of the stories that are included in the MAP, their organizations, all of the members of the PUA group, for your dedication to all of our activities, but specifically this one, since that's the one we're focusing on today. And to you all in the audience, I hope this was valuable for you, and I really hope that you add adaptations to the MAP and we can continue to keep this live and a learning resource as we go forward, both to learn from what we've been through and to prepare for sustainable services and for a next pandemic. Next slide. And finally, thank you so much to the IBP for hosting this with us and for hosting the MAP. We've run out of time, but we will answer your questions through an email document. Thank you so much.